Hello, welcome to the National Consortium of Telehealth Resource Centers Telehealth Hack Series. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. Our topic for today will be FQHC program models post-COVID. Next slide. Please know that any information that you provide today for your registration for the hack will not be shared with anyone. Next slide. The National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who are funded underneath the same program funded by HRSA. There are 12 regional resource centers that cover specific states and 2 national centers that cover policy and technology. However, all 14 telehealth resource centers work collaboratively together underneath the umbrella of the National Consortium of Telehealth Resource Centers. If you have any questions regarding telehealth, including program operations, technology, policy, we encourage you to reach out to your telehealth resource center, but know that since we all do work very closely together, when you reach out to one of us, you actually will get all 14. Next slide. The telehealth resource centers took over the hack series from ASPR when they began it back in the summer of 2020. They had a limited run of 10 weeks of hack series and asked the TRCs take it over in October of 2020. We've been continuing the series ever since, and it will run through March of 2021. Next slide. A few tips and notes for today's webinar. Know that your phone or computer microphone has been muted. If you have a question for our panelists, please utilize the Q&A function. The chat function should only be utilized for technical assistance with Zoom. Attendees are able to adjust the video sizing via the Zoom sliding feature, and know that closed captioning is available on for today's webinar. The button for the closed captioning is also on the toolbar. The webinar is being recorded, and the recordings will be posted on the NCTRC's YouTube channel and on its website. Next slide. CE credits are being offered for today's webinar. This is the disclosure policy underneath the University of Arkansas Medical School. Next slide. And the staff and other disclosure information. Next slide. Joint accreditation. If this is your first time asking for CE credits through the TRC Telehealth Acts, know that you will need to create a profile on the Learn on Demand website. So that is the URL for it. Once you create a profile or account, then you should be able to utilize that for obtaining CE credits for any of the future hacks. So you only need to create the profile once, but if you have not done so already, you will need to do that first time. Next slide. To get your certificates on the Learn on Demand system, you would log in, you search for the topic, and then once you find the topic, just launch, evaluate, and you can continue to print your certificate. Next slide. Please note that there is a deadline to get CE credits for this particular webinar. That deadline is February 24th. So you must complete the online form in order to get credits for this particular webinar. That deadline is hard and fast, so please keep a note of that deadline. Next. And again, just another reminder, the deadline, they really wanted us to emphasize this. Next slide, please. And now I am going to turn it over to Becky Bounds, who is with the TexLa Telehealth Resource Center, to introduce our topic today and our panelists. Becky?
Thank you, May, and welcome everyone. Today we have 3 speakers from federally qualified health centers across the nation from wide-ranging areas across the nation. As many of you, I'm sure, know, CMS Teleflexibilities associated with the pandemic allowed for the first time for FQHCs and rural health clinics to be distant site providers for telehealth. And so many FQHCs and RHCs ramped up telehealth operations to serve their mostly underserved populations. So we welcome 3 presenters today. First, we have from the Flathead Community Health Center, Leslie Diede. She has 20 years of healthcare experience, most recently at the Quality and Operations Manager for a federally qualified health center in Kalispell, Montana. As a part of this role, Leslie guided her organization through the initiation of telehealth services during the early stages of the COVID-19 pandemic. Additionally, Leslie oversees revenue cycle, risk management, and quality improvement activities within her organization. Followed by Casey Castner, has been working in telehealth since 2016. Through her role, she has learned the intricacies of the field, including equipment, IT, clinical aspects, billing and regulatory, and daily operations. She continues to work with Finger Lakes Community Health Center as the telehealth operations coordinator. And third is the Community Health Centers of South Central Texas. We have Rafael de la Paz. He is the Chief Executive Officer for the Community Health Centers of South Central Texas. He holds a Bachelor of Science degree from the University of Texas at Austin. He served as the COO for 4 years, excuse me, before transitioning into the Deputy Chief Executive Officer role at the center's succession plan called for. He has been with the center for nearly 11 years. Before accepting the executive role at the center, he worked in several departments and has held several roles within the center to include customer service representative, QI specialist, grant manager, and practice management director, offering him a unique insight into the inner workings of the organization. And again, thank you all for joining us today. And I will turn it over to Leslie.
All right, well, thanks everyone for allowing me this opportunity to kind of share our story from the Flathead Community Health Center. I'm Leslie Diede, and our Community Health Center, next slide, is located in Kalispell, Montana, which nobody usually knows where that is. So we are in the very upper northwest corner of Montana, right next to Glacier National Park, right next to the Canadian border. Believe it or not, we're a fairly populated county within Montana with 103,000 folks living in our county, but we're a rural area. Most of our county is rather uninhabitable because it's very rugged mountain terrain. It's part of the National Park Service. There's a protected wilderness area that falls within our county. So really, even though we're rural, most of our population really sits right in the middle of our county in our 3 major cities of Kalispell, Columbia Falls, and Whitefish. And just to give you an idea of the sheer size of our county, for those of you on the East Coast that are more familiar with Connecticut, we are about the size of the state of Connecticut in just our county. So next slide. Most people I always like to show off our county to kind of show what we look like and what we're really like here. So there's a few photos from our area. Like I said, Glacier National Park. We have some phenomenal downhill skiing in our area. A lot of wild and scenic rivers. It's just a very naturally beautiful area to live in. So just by looking at pictures, you can imagine tourism is a huge industry for us here in the Valley. And we also have some very wide-ranging socioeconomic status falling within our county. Some of the wealthiest of the wealthy living in areas of our county, usually in their second or third homes. And then we have a lot of very impoverished areas in our county as well, and a very high cost of living. I had to look at recently, and our average home price in our county is $450,000. So it's a very expensive place to live as well. So next slide. Our health center, just to kind of give you an idea of our size, we see about 8,000 patients a year. We have 9 sites. One is photoed there. That's our main site in downtown Kalispell. We have a site in a little tiny town called Hungry Horse, which is one of the more impoverished areas in our county. And that is actually run out of an old abandoned elementary school, but it is such a cool site. We have an addiction services site doing outpatient substance use disorder treatment, and we also do medical services in that area. And then we have 6 school-based sites that are doing outpatient behavioral health and medical services. And we do the gamut from medical, behavioral health, dental. We also have a Title X family planning program that's part of our health center as well. Next slide. So our telehealth journey, I would say prior to 2020, the mention of the word telehealth was never really met with any sort of warm reception. Usually patients and providers alike were saying they needed that face-to-face interaction. as Becky talked about, reimbursement for federally qualified health centers was not really an option. And then we have some unique challenges just based on our geography and our area of the country, with broadband being an issue. A lot of our patients don't have smartphones or even wireless connectivity in the areas that they live because of the mountainous terrain that we have. But really, it's something that was just new and unknown, so really scary for folks to think about prior to COVID. Next slide. So then COVID happened, and I say we entered the year of the pivot. In Montana, it was March 11th when we received our very first positive case. And I mean, to its blessing, I guess, it really kickstarted us into this implementation of telehealth. Next slide. So just some preparation steps we went through, as I'm sure everyone else did. We had to go through those electronic health record changes, but one of the biggest issues for us was really around this reimbursement thing and how much risk were we willing to take on. We had phenomenal support from our primary care association and the other federally qualified health centers in Montana, but there was a lot, I would say there was more questions than there were answers, especially in the beginning, about what reimbursement was going to look like. Was it really going to happen? How is this going to work? And so we just really sat down and said, well, if it works, great. If it doesn't, that's okay, because we're still doing what's in the best interest of our patient. And like I said, electronic health record changes. So implementing that module into our electronic health record, creating those visit types. Next slide. And putting in templates, so we ensured that our providers were able to chart all of those sort of necessary requirements for us. You know, do we have consent from the patient? Do we have those locations of where the patient and the provider were sitting? What type of methodology? Were cameras being used, or was it telephone only? And then we have this, it's really a dummy assessment code that we've added in. And we did that mostly because of our own internal reporting structure for different things, not just for telehealth. So that dummy code was a little bit of a way for us to work smarter and not harder, so that we can pull reports in the same manner that we've been doing for years, but adding in this telehealth component to it. It's not something that shows up on a claim, it's just a reporting piece for us. Next slide. We also spent quite a bit of time, because we had seen such hesitation from providers and patients alike. We spent a lot of time really going through what constituted an appropriate reason for a televisit, and just to make sure that providers were comfortable with what was going to happen, that patients were going to be comfortable with it. So we developed some lists for what would be appropriate televisit reasons, both medically and dental. We do dental telehealth as well. And then we just hit the ground running with training for staff, and we took off. And by March 23rd, we had fully implemented telehealth in our facility and started those remote visits. Next slide. I would say pretty quickly, we saw quite a bit of feedback from patients and providers alike. For the most part, patients were pretty appreciative of what we were offering, but there was a lot of frustration with the technology involved. We were actually seeing appointments getting dropped because of technology and a few other reasons, like providers running behind on schedule and patients giving up waiting for them. Of course, we still had this sort of question mark when it came to some of the reimbursement activities. But ultimately, the term that we kind of threw around was this was a saving grace. During COVID, this was a way for our patients to continue to have access to their providers in a way that they felt safe doing so during a very scary time. And it was a way for us to keep providers busy and able to be in contact and caring for those patients. That's why they're providers, right? Next slide. So after this sort of, I would say, initial bomb drop of we started this and got a little bit of feedback, we quickly jumped into quality improvement around our telehealth activities. We did patient satisfaction surveys for patients who did any sort of remote televisit. Overall, they were satisfied. Even with the technology, I would say the majority were satisfied, but those that were not were really unhappy with the technology piece of it. Ultimately, patients said that outside of a pandemic, when COVID is over, we want to come back in. We want to see our providers face-to-face for all of our care. Our quality council also set up a work group to work specifically on telehealth improvement activities, and we had representation from across every gamut of our health center. And those folks meet monthly and continue to meet monthly to make sure that we're offering the best and quality care that we can. Next slide. So some of our kind of key improvement strategies, as you can imagine, I've said it a few times, technology was an issue. So technology was number one on our list for making some improvements. One of the issues that we had was that providers in the beginning were using their laptops in a shared office space with another provider. So not great privacy that was going on. And patients ended up sort of looking up their provider's noses as they looked down on their laptop, which is not great. The other issue that we had with our health record, electronic health record, was that as we were using the telehealth module, the screen size that the providers were looking at that had the patient image in there was very small and not something that you could expand and make larger. And it also limited the provider's ability to look in other areas of the chart, like at previous notes or at labs or imaging. They were stuck in that progress note and couldn't go elsewhere. So with all of that, we decided to add Zoom so that providers could utilize the Zoom platform to see their patients and interact with their patients, but then sort of had free reign to be in everything else that they needed to do within that electronic health record. We set up exam rooms that were more private to have better technology for providers to have good cameras, bigger screens, and then there was never this shared space with another provider essentially listening in to a televisit. We set up designated telehealth gurus. So we trained some of our staff and they were really those #1 contact folks to make sure providers had access and patients had access to their televisits. We changed around some scheduling so that all of our televisits occur at the beginning of a shift. So a provider would never end up running behind because there was a complex medical issue that happened here in the clinic that put them behind for their televisit, so that patients weren't just sitting, waiting, staring at a blank screen. We also really took advantage of the time that providers had previously been spending on the phone with patients, either talking about test results or medication changes or those lengthy phone calls that providers a lot of times get into with patients that really do meet the quality or criteria for a visit, but we've never been able to document and bill for that in some way. So we've set up some protocols to be able to do that. Next slide. Just other pieces we made, all of our behavioral health and our psych appointments via telehealth. We also are actively transitioning any medical visit for a behavioral health reason, such as anxiety or depression, that we're transitioning those. Other visits are like med refills, follow-ups, those kind of things are automatically televisits for us. And then we had to address this issue with our patients that don't have access to internet, or maybe don't have a cell phone or a smartphone or any other way to really communicate with their provider remotely. So we do have in-office televisits, which sounds kind of strange, but patients are able to access the technology within our facility, but not in a crowded area, waiting room or an exam room. It's just a very secluded area, but that they can access that technology to get it onto their televisit. Next slide. So for us, I would say quality improvement is still continuing. We're trying to still figure all of this televisit stuff out. We still have some questions surrounding reimbursement. We've had some challenges there, to say the least. But ultimately, we're moving forward, and I think it's something that we're all hoping will stay once the pandemic is wrapped up. But we'll keep moving forward. And I just had to end with one last photo of our beautiful valley, and it's definitely the road to my happy place. So I'm sharing all of my happy place with all of you. So next slide. There's my contact information. If anybody wants to reach out for free, I'm happy to answer any questions, even if it's just about the beautiful area that we live in. So thank you. And I think we're doing questions at the end, but thank you.
All right, so my name is Casey Castner. I am the Telehealth Operations Coordinator at Finger Lakes Community Health. Next slide. So who we are a rural FQHC in Finger Lakes region of New York State. We're well known for our wine country, lots of lakes. It's a really gorgeous place. A lot of people go for summers. So we at Finger Lakes Community Health, we provide comprehensive medical, dental, mental health, substance abuse, nutrition, care management, and advocacy services to the communities that we serve. We have 8 health centers. We have a community portal dental program. So we go to schools, Head Starts, and jails. We have a mobile medical program for farm workers. And extensive care management services. So some 2019 UDS data that we pulled, we had 28,927 total users. Of those users, 7,000 were agriculture workers. We started as a migrant care project, and so we retained a large number of that population of patients. And of our patients, 64% of those patients wanted to be seen in a language other than English. So we do a lot of interpretation services, and we actually utilize telehealth for a lot of those interpretation services. Next. So some terminology that I'll be using, just to go through really quick. The originating site, this refers to where the patient is physically located while receiving telehealth services. And the distant site refers to where the consulting specialist or the treating provider is physically located when providing telehealth services. Next slide. An internal program, this refers to when both the patient and the provider are physically located in one of your health centers. So if we have 8 health centers, so a lot of times patients will come to a health center in one of our counties and they'll see a provider either for primary care or behavioral health or nutrition, whatever it may be. They'll see a provider who's located in another one of our health centers. So both patient and provider are physically located in one of our health centers, and that's considered an internal program. An external program is when the patient is physically located in one of our health centers and the provider is located at an external health center that does not belong to us. So the patient will come into one of our health centers and they'll see a specialist or some external provider who provides care outside of our program. And then direct to consumer program. This is the type of program we've seen pop up a lot due primarily to response to COVID. This is when the patient is physically located in their home and the provider is either located in your health center or the provider could be located in their home as well. Next slide. So telehealth services that we offer at FLCH, we've been doing telehealth at Finger Lakes since 2010. We started in 2010 with a telepediatric dental program. We had a really hard time getting kids to go all the way up to the city to have a consult with a telepediatric dentist to get any sort of treatment done. So we decided to work with them and do the consults via video. So that initial piece, they would just come into the health center that they had already been a part of forever. They knew how to get there, and they would come in and we would connect to the pediatric dentist via video, and they would do the entire consult via video and determine the treatment plan then and there. So that's our oldest program. We've had over, I think the last poll that we did, we've had over 900 kids go through that program and successfully complete treatment. Before we started telehealth, we had a completion rate of about 6% of kids who would actually finish treatment and come back to the health center for the 3-month follow-up. And now we're at somewhere between 90 and 95%. So a very successful program. That was our initial program. We also do teledental exams. So from the start of the pandemic, we had a dental provider who did not want to come into the health center. So she works out of her home and she sees patients for dental exams in our health centers. The patient comes into our health center and the hygienist will telepresent the patient to the dentist who is at their home. And this has actually really helped with workforce shortages because our dentists can now see patients in a bunch of our sites instead of just having to be, in site A all day. And if there's a no-show, that's kind of what it is. Now she sees patients in all 8 of our health centers throughout the day. So we've really been able to fill her schedule. We work with a psychiatrist in New York City. So we have a telepsychiatric program that's external. And we also have a psychiatrist of our own who's on site. And she sees patients both from home and she sees patients in the health centers. We have a telemental health program. digital retinopathy screenings. This is our only asynchronous telehealth program. So we take pictures of the eyes and we forward it off to an ophthalmologist who will read it and send us back their results. And then we can create a treatment plan based on the results. We have tele-registered dietitian or a nutrition program, telepediatric neurology. We work with a psychiatric nurse practitioner based out of Rochester who sees patients of ours who are children with uncontrolled ADHD. So she has a large caseload of kids that she manages. We work with an infectious disease provider in the city, and they offer tele-HIV and AIDS care, tele-Hep-C, tele-TAC, which is treatment adherence counseling, tele-LGBTQ+ services, tele-hormone therapy, and yeah, so they'll see all of those patients. We've had that program for a number of years as well. And that's really helped us to be able to increase access to patients who have not been able to seek treatment because of either distance or travel, or they don't have interpreters where they're going, whatever it may be. They can just now come into our health center and see these providers in the city. We do a lot of interpretation services. So we have a number of interpreters who will sit at one of our sites and they'll provide interpretation to all 8 of our centers. We do provider precepting through telehealth. We have recently started a virtual reality program where patients who are coming in for visits that induce anxiety, such as PAPs or IUD placements or immunizations or blood draws, we can offer them the virtual reality units, and it allows them to there was a study that was done on virtual reality and being used in the health center. And it showed that it actually decreased the anxiety in patients and created a safer and a better experience both for the patient and the provider who was working with them. So we've started that. We do a lot of primary care visits. So we have a direct-to-consumer program where our providers will be in either the health center or in their homes, and they're seeing patients in their homes. But we also use primary care internally as a way to cover health centers that may not be staffed with a provider 24/7. So if we have a walk-in come into a health center that doesn't have a provider, that patient can still see one of our providers at a different health center. We'll just see them virtually. And then, as I said, we also have a large number of direct-to-consumer visits. We started direct-to-consumer at the start of the pandemic in like March. When we shut down, we really bulked up our direct-to-consumer platform. And now we see a large number of our patients that way. Next slide. So the effect of COVID on our telehealth program, because we've had a telehealth program that's been around since 2010, we've had a pretty good process in place. With the pandemic and the state of emergency, a lot of regulations have been relaxed. We're being reimbursed for telephonic visits, things that weren't around before the pandemic, but we decided not to relax our program, not to change anything, because we don't know what's going to stick around once the state of emergency is lifted. So we decided to just keep doing things the way that we've been doing them in terms of regulations and reimbursement. And that way, if the state of emergency is lifted and things start rolling back, we don't have to try to, run around and figure out, okay, how are we going to make this program work now? And how are we going to make it compliant with the new regulations? Next slide. So 3 of the main challenges that we've seen as we've built our program, especially during this year as telehealth has really started to increase, is finding a video conferencing platform that fits the needs of all of our telehealth programs and our administrative video conferencing needs, staff buy-in, and internet connectivity for our patients, which is huge because we're in such a rural area that having consistent internet connectivity for patients is very difficult to come by. Next. So to address the platform piece, we created a platform selection matrix that allowed us to really take a look at, for a while, we were using 4 or 5 different platforms. We had Movi Jabber, Cisco WebEx, Zoom, Ignite, Microsoft Teams. We just kind of had a bunch of platforms that we had, popped up to address administrative or our direct-to-consumer platform. And so we really took the time, we wrote down all the platforms we had, we identified what our organization actually really needed out of a platform. And we also identified things that were kind of on like our wish list, things that were like, it's not important, it's not absolutely necessary that we have this, but it would be really nice to have X, or we're not doing this yet, but in the future we'd like to have this, so we want to make sure that the platform is capable to grow into that. And we wrote all of those down, and we looked at what our current platforms offered, and we even looked at a couple of additional platforms, and we filled out the matrix so that we could really see, okay, this platform is actually what's going to work best for us, because it's natural for different people in the organization to form ties to platforms. So a lot of times, you know, like provider X wants to work with Zoom, provider Y wants to work with Cisco, and provider whoever wants to work with a different platform. But that can be really confusing for patients, and that can be really confusing for staff. And it doesn't necessarily lend itself to a sustainable program. So we sat down and we took the biases out of it, and we did a firm look at, this is what is actually beneficial to us, and this is what's not. And we were able to decide on a platform to move forward with. And we communicated that out to our staff, and we developed a training plan, and it really helped to simplify things. And it helped to simplify training for patients and training for staff, and also our IT support role. So we have a telehealth group who's responsible for troubleshooting platform issues with our patients. It was really difficult when they had to troubleshoot a number of different platforms. So now we have one as we move forward, and it's made it a lot easier. Next slide. For staff buy-in, what we found to be the best way to improve staff buy-in is just making sure that our telehealth workflow was as close to our program's in-person visit workflow as possible. It's really hard to get staff to buy into a workflow when it means that they have to do things completely different and go outside of the workflows that they already have ingrained. So we wrote out our entire clinical workflow, and we looked at how we could incorporate telehealth into that workflow without making it more difficult. So we have equipment in all of our exam rooms. And that allows us to room virtual patients the same way we would room in-person visits. So if a provider is in exam room A, the nurse can go into exam room B, they can room the patient virtually, bring them up on the screen. And that way, when the provider is done in exam room A, they can just walk into exam room B and see the patient as they would. And that really helps to keep things moving. It helps for providers to buy in because they don't have tech issues that they have to worry about. They don't have to try to connect the patient themselves. It's just very seamless into the workflow that they already had. It also makes telehealth training easier and smoother because we don't have to train on a completely different workflow. We just get to take the workflow we have and incorporate the technology into that. Next slide. And then internet connectivity for patients. We've done a lot of advocacy for community bandwidth in rural areas. We're still fighting for that for our patients. We've talked about and we've started to implement community internet hubs so that patients can go to a location that has hotspots so they can connect and be able to see their provider that way. But the biggest thing that really helped us address this was we introduced a bandwidth questionnaire. So whenever we identified a patient or a patient identified themselves as wanting to have a telehealth visit, we would immediately ask them a bandwidth questionnaire, which was, I think it was 4 or 5 questions that went through, okay, do you have a smart device or a laptop or a computer? Does that computer have audio and webcam capacity? Are you able to stream Netflix or YouTube in your home? And by asking these questions, we were able to ask the patient about their bandwidth without actually asking them about their bandwidth, because patients don't know what bandwidth means. So if a patient is able to stream Netflix in their home, chances are they have enough data or whatever it may be that they'll be able to have a video conferencing call. And then we would ask questions about, do you have a data plan? Do you have Wi-Fi? Do you have connected internet? And that helped us to weed out folks who would not be a good match for telehealth. And we could, set them up with either a telephonic visit or have them come into the health center. But that took the frustration off of the provider, because what would happen is the patient would try to connect at the time of their visit and have no idea that their flip phone doesn't allow for them to connect to a visit. So they'd be trying to talk on the phone with their provider, and the provider doesn't know how to troubleshoot, and it just caused a lot of frustration. So by having this bandwidth questionnaire, we could determine in advance who was going to be a good candidate for telehealth and get rid of the frustration down the line. Next slide. So plans for 2021, we're planning on implementing an RPM program, which is remote patient monitoring, especially as we have patients who are quarantining or homebound. We want to make sure we're still collecting that clinical data that's used to help us determine treatment plans, and remote home monitoring is really the way to go with that. We're also in the process of converting to our new platform. We've been working with our engineers to build the platform, and so we're in the process of piloting that now. And we're in the process of integrating our interpretation software with our video platform, which will allow us to, if we don't have an on-site interpreter available, or we don't have an interpreter available for the specific language, instead of having to bring up our interpretation software and our video platform on 2 separate devices, we'll be able to do an integrated 3-way call. So those are kind of our plans for 2021 moving forward. Next slide. And that is it. That's my contact information. And I think we're doing questions at the end.
Hello, everyone. My name is Rafael. I'm the Chief Executive Officer for the Community Health Centers of South Central Texas. And thank you for allowing us to share our story as well with you all. Next. So we're an FQHC that operates out of 8 different clinic sites across 5 different counties. Our region, our coverage area, if you will, expands from northeast of Austin down to close to San Antonio. And then we have another site here down in Victoria. Essentially, our area is between the Elgin site and Victoria site is about a 2.5-hour drive. So it's a pretty broad area, and the majority of those locations are in rural settings. In 2019, we served nearly 20,000 patients and generated close to 65,000 visits. Next. And as our counterparts, or actually as Lacey kind of mentioned, really with us, telehealth was really more a response to the COVID-19 pandemic. And so at least our story is in early March, we started seeing cases being reported in San Antonio and in Austin. So our leadership began having conversations and coordinating kind of the next steps to ensuring that we will be able to still provide care to our patients with eliminating the risk of exposure. And so some of the things that we started doing early on was changing the hours of operation. A lot of daycares and schools started to close down. So therefore, we were short on staff and therefore had to shorten our hours. In addition to that, we began doing telephonic screenings to ensure that any patients that came in had not been exposed, started scrubbing our schedules as well and removing anyone that was non-emergent. Also, what we started doing was we reached out to our patients, started providing at least 30-day supply of medications to kind of hold them over. And then also one of the main things that we were really wanting to do is really kind of eliminate or reduce the foot traffic in our locations. So we asked patients to stay in their vehicles until they were ready to be seen. We started offering curbside visits and also testing. And of course, dental services were being postponed at all of our sites and only emergency services were being offered. Next. And so with that, one of the things that we looked into was, how to roll out telehealth visits. And so our center decided to utilize UpDocs. It was a solution that, although not perfect for us because it was not integrated with our EHR system, it was something that we knew that we could roll out pretty quickly. And again, being able to provide care to our patients was our priority at that point. And so on March 19th, we had our first televideo that was piloted in Gonzales. And by the 23rd of March, we were essentially all the medical and behavioral health providers were utilizing UpDocs. And so at the end of 2020, what we saw was that we nearly saw 18,000 telehealth visits, which is currently about 48% of all of the visits that we're generating. And if you see on the graph on the left, before COVID, of course, we did not provide any telehealth visits. And so by March, 74% of our visits were being provided through telehealth. And now it's kind of plateaued. where we're bringing in still some patients, especially those that are well-child checks for immunizations, as well as woman exams. Certain services are coming in now into our clinics. On the right graph, you'll see kind of the mix, if you will, between televideo and telephonic visits. We're still struggling. We're still having a huge amount of telephonic visits compared to televideo. That's something that we're working on. And of course, it has its challenges, and why we essentially have challenges as to why we have so many telephonic visits. Next. And so some of the challenges that we've encountered early on was really kind of the urgency around COVID and having to roll out something that was quick. And so we didn't really have much planning or time to plan. And so therefore we lacked experience. We didn't have the workflows that were necessary to really kind of get our patients in. When it came to scheduling, consent, screening, we didn't have the equipment. And then of course, also the billing concerns, as was mentioned by Leslie early on. And so one of the things that we thought to ourselves was, as an organization, and knowing that we serve the most vulnerable, was that we're going to roll out the services, we're going to provide the services, and we would worry about the reimbursement on the back end. Thankfully, our PCA also in Texas did an incredible job early on providing us with that information and really kind of walking us through the best way to get that reimbursement for those services. Next. Some of the best practices, if you will, that we learned through the early implementation was really kind of the key things that really helped us was developing specific workflows. So on the right, you'll see this is kind of a workflow that we developed for our telephone visits. And it was key for our staff to visualize, if you will, their specific part to that visit. In addition, we started doing, and we're continuing to do, some staff is not necessarily dedicated, but the MAs that are calling the patients to get some of their histories, they're also kind of working some of the technical issues with the patients before the telehealth visit with the provider. So that allows at least time for them to kind of work out some of those issues. But unfortunately, a lot of those visits that start off as a televideo visit end up as a telephonic visit. And really it's around the lack of or poor connectivity on the patient side. The other thing that we also adopted was electronic signatures. We utilized DocuSign, being able to get those consents and forms filled out prior to their visit. The other thing that we really kind of built on, and we're still utilizing it, was really kind of just being able to get a mass message out to our patients through websites, our social media platforms, and then also our text messaging platform, which we utilize Care Message. It was great. We're able to send out a bill link. They were able to access our website and get information as to what they would expect from the televideo visit. The other thing that we're using right now, Care Message as well, is as we're rolling out our vaccines, being able to gauge as to what folks are interested in getting the vaccine, and then reaching out to them whenever we're getting those allocations to schedule them to come in. The other thing that was really helpful as well was kind of getting a list. This is for our schedulers, getting a list of the different visits that were appropriate for telehealth, and that really helped being able to get those schedules filled in a manner where we didn't have to go back and reschedule them for a face-to-face visit. Dual monitors was huge as well. Headsets for providers, so the things that are great, being able to chart in one screen and then being able to go to the other screen and have the patient there was also great. Next. So some of the benefits that we've seen, both on the patient side and also the provider. Patients, of course, we're really thankful to be able to still get access to care without the risk of exposure. Very convenient. No need to take off work. Again, we serve 56% of our population is uninsured, and so these are working families that when they're off work, a lot of them don't have the benefits, sick leave, and so taking off work is quite a bit of a stressor on them. And so being able to take the care to them, it's huge. Not only that, but transportation, when we're speaking of social determinants of health, transportation may be the largest issue that we see with our patients. And so again, being able to have that type of model where we're able to take the care of them through telehealth is great. On the provider side, again, they were really thankful to being able to still continue to serve their patients and provide care to them. One thing that was really neat was looking at our no-show rate specific to the telehealth visits. Just in January, we had a 1.5% no-show rate on telehealth visits. And so again, that's something that in the past has been a stressor for us, being able to reduce that no-show rate. Again, patients are happy. That's what they're telling our providers. It also increases our capacity. One other percentage also mentioned this. It's some of our sites are being taken care of by just one provider. And so when that provider is out, it means that we have to reschedule all these patients that unfortunately they've taken off work, they've and planned their day around that. And so being able to plug them in, if you will, with another provider that can provide telehealth. Not only is it beneficial for the patients that they're able to get that access, but for us as a health center, we're still being able to get revenue off those services. Next. And with that, I think the last thing I want to kind of mention is really just the importance of around advocacy. I think Casey, I think their group has a lot more experience with telehealth, and I think they demonstrated really the importance of telehealth and how much it can actually grow here in Texas. We don't have the same opportunities. I think we've had a lot of different restrictions that have not allowed us to kind of grow within telehealth. So again, advocacy right now, it's going to be huge, not only at the state level, but also at the federal level to ensure that these services continue to be reimbursed the way they are. And with that, I just want to say thank you.
Thank you, Rafael. Thank you to all of our speakers. I'm going to ask that everybody please come back now for our Q&A portion. The first question that we have, and got asked this several times, so we'll just get this one out of the way. Casey, would you mind sharing your questionnaire about bandwidth capability to patients? There were quite a few requests for that. I don't know if that's something that you are willing to share with the audience. You're a little choppy, Casey. I think the connection.
My team to make sure
You're still a little choppy. I do know Casey was in transit, so she might be in a bad area right now.
And I'll get back to you and let you know.
Okay, great. So Casey will let us know if she's able to share that. And if she is, then we will find a way to link it when we have the PowerPoints up and available. So let's go on to our next question here. What did staff training look like and what topics were covered in the training for those who had some sort of staff training?
So with our staff training in the Flathead, we really just focused on what is telehealth, what's an appropriate reason for accessing a visit remotely like this. But a lot of it was just the terminology pieces, the technology pieces, so that no matter who a patient ended up communicating with, they were getting the same answer. So it was a lot of just that language development essentially for our staff. And then we got into some more of those technical pieces about how do you access the technology? What do you do if a patient can't connect, if they're stuck in a screen, if the link wasn't set? So it depended on the level of that staff education, but ultimately everybody received some sort of training about the tech or the terminology pieces so that we were all speaking the same language. Providers, a lot of it was on the documentation pieces. Our billers, oh my gosh, our poor billers, to make sure that we were getting reimbursed. We spent a lot of time going through all of that. And we're still seeing issues, as I'm sure everybody else is, that we're learning as we go, so.
Rafael or Casey?
Yeah, so at least for us, kind of the same thing on some of the training. I know our IT folks essentially developed some videos where they were sharing with different providers on kind of the steps, also some slide decks to on just kind of the steps navigating the system, and then they also had one-on-ones if they had any issues. We also had some IT folks that were available on call, if you will, for those providers early on.
Can you hear me better now?
Yes, definitely.
Okay. Sorry about that. So yeah, for Finger Lakes, the training we have new hire orientation, and all of our staff get a 30-minute overview of telehealth and the history of our program and the services that we offer. And then anyone who's identified as having a further role in telehealth, like clinical staff, behavioral health folks, whoever it may be, they go through a 4-hour orientation where we do an in-depth dive in how to document, how to code, how to schedule, how to use the equipment, how to telepresent. And then we actually send them back to their site to continue to work with either their lead RN or their supervisor until they can demonstrate that they can perform a telepresenting or whatever their role is, a televisit independently, and then we sign them off as competent. And that's just really helped us to be able to have accountability for our staff, but also to make sure that everybody's getting the same level of training and understanding of the program.
Great. Actually, spinning off of something that Leslie said and Rafael had at the end of his presentation there, we have a question from Carlos that says, what have been the main reimbursement issues faced during telehealth implementation, and how did the centers find a solution to their issues?
So the big one has been obviously with Medicare and this whole, oh gosh, I wish I had a biller sitting right next to me, but just some of the coding pieces. In fact, we had Medicare do a take back, which we're assuming is part of a sort of fix as they're adjusting for all of those telephone only specifically codes. So Medicare's been a challenge for us just in making sure that we're documenting appropriately and that we are actually going to get paid. And I'm assuming that's not just unique to us. I know other health centers in Montana are experiencing that. I would assume that's across the country.
Yeah, I would add to that, Leslie. The same thing. Medicare has been an issue with us. Although we were told that some of the restrictions were removed, there still has been a significant delay on getting paid for some of this, is specifically the telephonic aspect of it. For us here in Texas, we had quite a bit of an issue as well when it came to Medicaid and the managed care organizations here. And so again, just with whenever they uplifted those regulations, it allowed us to get some of those services reimbursed.
So I think this next question might only be for Casey because I did hear her mention it specifically, but involves teledental. There was a question regarding whether can you do teledental through audio only, since audio only has played such a big part during the pandemic?
So for us, the teledental that we're doing is a full examination so that we can bill at a higher level. So no, we can't do teledental exams through audio only. We use the medical peripherals, the oral camera, to make sure that we have a full examination take place. You can do teledental asynchronously, which means that you take like a camera and you have somebody who takes pictures and forwards it off so that you don't have to have that video conferencing element. But I don't think that you can have a very comprehensive dental exam audio only. Yeah, so we're not even providing dental services to patients in their home. Like the patient has to be in the health center with a hygienist so that we can have that full exam take place.
Thank you. This is actually an interesting question. Curious about the amount of time providers are spending with patients in telehealth. Is it the same time as it is with the in-person face-to-face, or have visit times decreased? I've had visits with my own provider that are 7 minutes long.
So just on our end from the Flathead, our providers' visit times are the same. We're including, now that we have Zoom abilities, we're including the nursing part of that video. visit into that overall. So our appointments are usually 20 minutes. So you're spending a few minutes with the nurse, and then yeah, your provider face-to-face time might be limited, but it's the same as if you were seen here in the clinic in person. So times for us haven't changed.
Yeah, same here. I don't think we have made any changes as to the length of those visits. Some of the feedback that we got early on from our providers was that they felt that the telehealth, going telehealth, it almost seemed like the visit was just kind of more just to the point, if you will, to the chief complaint and taking care of those things. So it almost seems like it actually reduces some of that time with the patient.
Yeah, for us, I would say the biggest thing that we found in terms of time is actually the wait time. So like when patients are in the health center, they're able to check in with a receptionist or whoever to say like, hey, you know, why is my appointment running late? But when patients are hanging out in like virtual land and they have no one to talk to, there can be a lot of frustration in terms of like wait times. So, you know, we've implemented policies and procedures around how long can it go, like can an appointment go before we have that first touch with the patient to make sure that they know that somebody's going to see them. How long can we go from, you know, that first touch before we send a chat message to the patient to say, hey, your provider's running late, they're on their way. So I think the biggest thing in terms of timing that virtual visits have changed with us is just that communication level with the patient.
Mhm. We've got a couple of questions about platforms and basically how you went about deciding which platform to use and what platform are you using?
So for Finger Lakes, we developed that matrix, and really what the matrix was for us was we just identified key important things that we needed. So for us, cost was a big one, the ability to have more than 2 people on the call because we frequently use interpreters, and the ability to replicate a virtual health center. So like I said, we wanted to make sure that we could replicate our in-person workflow as much as possible, which means that we have a front-end person getting on the call and verifying demographics and insurance and collecting payment. And we have the nursing staff getting on the call and doing, you know, PHQ-9s and any pre-clinical work that needs to take place. And we have interpreters able to get on the call. So we needed to make sure that we had a platform that could fit the needs for a virtual waiting room. So we took our in-person workflow and we pulled out what was necessary, and we created our matrix based on our organizational need assessment.
So for us, we are on an eClinical Works in our clinic here, and that's the module that we started with, or the platform that we started with. Like I mentioned, we had a lot of trouble, and one of the biggest things for us is that inability when you're using the ECW platform to get into other areas of a patient chart. A provider wants to go back and look at labs or imaging or previous notes, and you could not do that with ECW televisit platform open. You also couldn't open another instance of ECW to be able to do that separately. So you literally would have to use 2 separate devices. So we're pushing more and more towards Zoom. Our behavioral health visits are all via Zoom, and we're pushing more and more of our medical appointments that way. But ultimately, sometimes our patients are really the deciding factor. Because we started with our eClinical Works platform, patients got used to it, they're comfortable with it, they want to stick with it, and that's fine. We're going to let them do that. But for any kind of new ones moving forward, we're really pushing those folks to use Zoom.
And as I mentioned, we utilize UpDocs, and for us, the number one thing, important component of it was the cost. We didn't know we were going to be reimbursed for the services, so we needed something that was going to be low in cost, and then of course something that we would be able to quickly implement, which UpDoc offered that as well.
And I'm sorry, but I think that's all the time we have for questions. I know there were a lot more. This just really speaks to the quality of speakers that we had here, that we had so many questions that we could not get to. So I just wanted to say thank you again to Rafael Leslie, and Casey for their wonderful presentations and for taking time out today to present on this telehealth hack. Thank you also to Becky Bounds for pulling this together and for reaching out and finding these wonderful speakers. I hope folks have learned a lot from these presentations. I know I have. So just to let you know, some upcoming sessions, we do have another session in February. It is again on program models post-COVID. We're going to look at health professions training models in post-COVID-19. Our March sessions, have them scheduled for March 10th and March 21st, so stay tuned for more information. Registration information for the February webinar is on the Telehealth Resource Center website, telehealthresourcecenter.org. Please remember to fill out your evaluations. You'll get one after the session. That would really help us out. And also, again, if you are interested in getting CE credits, there is a specific deadline for that. That is February 26th, I believe. So please get your information in before that if you want to get your CE credits. This webinar is being recorded. It will be posted on the YouTube page for the consortium. It will be posted on our website along with the PowerPoint presentations. Casey will check to see if she can have those bandwidth questions distributed. If she can, we will also have that on our website. Once again, thank you to Rafael, Casey, and Leslie for your wonderful presentations, to Becky Bounds for helping to organize this, and thank you to everyone out there who attended. Have a great day.